Hello and welcome to the Compass webinar for March. This is Dr. Eric Bricker and I'm the Chief Medical Officer and one of the co-founders of Compass Professional Health Services. The topic for this month's webinar is the Snowball Effect, why selecting a doctor is one of your most important healthcare decisions. And I thought when we were coming up with this title, I'm like, there's no way that we should be talking about snowballs in March. But apparently I was completely wrong because with the 4 nor'easters that hit the Northeast of our country, there have been tons of snowballs in the month of March. So if anything, it was incredibly appropriate for us to talk about snowballs in March. And however, here in Dallas, where we are, fortunately, we have not had any snow recently. And I'm just so happy to have all of you today here with me. Many of our existing clients are on the call. We have a lot of our broker and benefit consultant partners, vendor partners, prospective customers as well. And so if you are new to joining our webinars, welcome. And obviously, if you've been to previous webinars, welcome as well. As per our theme this year, we're trying to incorporate our actual employees in the pictures. So here we got some actual employees, and this is downstairs in our building. We're in the Bank of America Tower, which is right in downtown Dallas. So that is our building. And there's a picture of yours truly. And of course, we have to have a picture of me. No, just kidding. Probably better if we didn't. But I am the Chief Medical Officer. Like I said, I'm a general internist and I did my residency training at Johns Hopkins in Baltimore. And as many of you know, I was a hospital finance consultant before going into medicine. So I used to be in the billing and business office of major medical centers before I went into medicine, and just saw a lot of confusion and frustration back in the business office, and saw the sort of a similar confusion and frustration at the patient bedside. So myself and my Compass co-founders said, well, as doc and hospital insiders, if we could take what we knew and bring that to companies and their employees, that would be potentially valuable to them. And that was kind of the beginning of Compass. And we've been supporting clients now for over 10 years. Again, those are some of our employees down there, about 260 employees ourselves, about 2,000 employer clients. Subscription model, PEPM, in terms of how we charge. Implementation for a lot of our smaller and mid-market groups is 6 to 8 weeks. And for a lot of our larger, jumbo or large account clients, oftentimes it's kind of 3, 4, 5 months of implementation. We have helped people navigate the healthcare system 1.35 million times. So as we say here in Texas, this is not our first rodeo. And so you name the healthcare situation, we have probably helped one of our members deal with it, including people with conditions where they had to get on a plane in Alaska and fly down to Seattle, including conditions like involving interventional radiology cryoablations from your run-of-the-mill x-rays. So you name it, we have done it. And then utilization is about 25%, which is 5 times the industry average, again, because we really cultivate trust. And by utilization, this is like real utilization. This is like people have actually interacted with us. It's not just downloads. It's not just like putting the app on your phone. I mean, this is actual solutions from Compass. And so let us get into today's topic of the snowball effect, why selecting a doctor is one of the most important healthcare decisions. And specifically, one of the reasons that we're talking about finding doctors is because really that's where the magic happens in healthcare to improve a member's or a patient's health. And it's in that doctor-patient relationship and an effective diagnosis and an effective treatment plan, which then leads to a good outcome. And that's really done at the doctor-patient level. And so we at Compass, if we can be sort of that administrative healthcare or medical home for the physician and their patient, so that they can focus on all the clinical medical stuff, and we can focus on all the administrative bureaucracy, cost, paperwork side of things, then it really allows that doctor-patient relationship to be really what it's supposed to be. And so obviously, one of the things that we do at Compass is to match people up specifically with physicians that are high quality, cost effective, and really meet that specific profile of what our members are looking for so that they can really establish that doctor-patient relationship. Vis-a-vis kind of what people do now. If they don't have any type of healthcare navigation service to support them, what do? Well, like most people, they typically ask their friends or family. That is the most common thing that people do. Or they might go on to Yelp or Google, and they'll just find somebody that's close. Or they might go on their insurance carrier website and just find somebody that's close, or find somebody that just has good appointment availability. Oh, I can be seen later today or tomorrow or later this week, or I only get off on Tuesdays and Thursdays, and so it has to be a Tuesday or a Thursday. And the thing about the location or the appointment availability or just the referral from the friends and the family, it's that, does that mean they're competent? Does that mean they have a good bedside manner? Does that mean that they have expertise in the specific area that you might need help with? And so those are common challenges, or maybe even mistakes, that people encounter when they use those methods for finding a physician. And so here's an example of the snowball of what happens when somebody does find really the wrong doctor. So the orthopedist, let's say they're having a musculoskeletal issue, or they have like a sprained knee or a sprained ankle. An orthopedist might refer them to expensive imaging that's 2 times more expensive than the area average, like an MRI. And then after looking at the MRI, the orthopedist pursues surgery instead of more conservative therapy, which might be like physical therapy. And then not only do they do surgery, but they do it at a facility that's 3 times more expensive than the area average. And then as follow-up to the surgery, a physician prescribes let's just call it a non-opioid pain medication that is brand name and exceedingly expensive. We'll see in an example later on here that there is a medication called Duexis, which is a combination pill of ibuprofen and Pepcid that's incredibly expensive. And both of those medications can be available on either a $4 prescription list if they're prescription strength, or or over the counter. So what happens when you pick the wrong doctor? So one is that going to see that physician can oftentimes result in then subsequent referrals. So there's over 100 million referrals in the United States every year. And so oftentimes there's kind of 2 categories of referrals. There might be what we consider self-referral, where the person just finds their own specialist, or there could be referral from one specialist to another specialist, or there could be referral from a specialist to a primary care doc, or referral from a primary care doc to a specialist. But probably the 2 most common scenarios are specialist to specialist referral. Common example there would be like, hey, you're having problems with a chronic sore throat. You actually go and see an ear, nose, and throat doctor because you're having a throat problem. They do a nasopharyngoscope, look in the back of your throat, and they see evidence of burning of your esophagus from reflux, and they send you directly to a gastroenterologist for your reflux. Well, both of those things could have been assessed and diagnosed and treated by a primary care physician. And the PCP themselves, they oftentimes do not know the quality or the cost effectiveness of the specialist they're referring to. Oftentimes, they're just kind of asking around to their friends, or it might be somebody that they saw on rounds at the hospital, or it could be somebody who just frankly refers patients back to them. And so there is somewhat of a quiet handshake agreement where, hey, if I refer a lot of my heart patients to this cardiologist ends up referring a lot of their people that need primary care providers back to me. And so it's really more of a volume, like drive-in patient visits sort of reason than it is actually based upon, oh, I know that their outcomes and their quality and their cost effectiveness are what's going to be the best for my patient. Now, I'm not trying to be overly cynical here. But the point is that when you're making these decisions that you don't often make, right? Because healthcare is pretty episodic, is you want to have those decisions be as rational as possible and as free from a variety of sources of bias as possible as well. And one of the major things that's happened, this last point here on this slide, hospital-owned physicians cost 10.3% more than physician-owned practices. That's where really that movement, really over the past 5 to 10 years, where only about 10 to 15% of physicians were actually employed by hospitals only 5 or 10 years ago. And now it's well over 50%. It might even be 2/3 of physicians at this point are actually employed by a hospital. And those hospital-owned physicians end up costing more because there oftentimes is either direct or indirect incentive for them to order more tests or procedures at the hospital system that they're associated with. And so again, that's a bias, right? And maybe it's appropriate and maybe it's not, but that's a bias that needs to be acknowledged. Okay. And then when people are referred, specialist, oftentimes they are sent for too much testing. 30% of medical tests and procedures are unnecessary. That's according to an Institute of Medicine study that was very famous. Many upper GI endoscopies or an EGD are oftentimes not necessary because one of the most common symptoms that people have or complaints would be for heartburn. Now, if you have heartburn without any red flag symptoms to indicate things like a blockage or a stricture with food actually getting stuck in your esophagus on its way down, then oftentimes you do what's called a therapeutic trial where you'll put somebody on an antacid medication, either an H2 blocker like Zantac or a PPI like Protonix or Prilosec. And those are brand names. They all have generic names in the mail, like pantoprazole and omeprazole. And if that makes things better, then oftentimes success is achieved, and you actually don't need the EGD. And so it is it's a rather subjective requirement as to whether or not people actually need those GI endoscopies. So oftentimes people get overscoped. There's excessive stress tests and echocardiograms oftentimes for people without heart-related symptoms. Or if they do a stress test, oftentimes if they're low risk, they could do what's called a treadmill EKG, which only costs like $180 and is more than adequate versus one of these nuclear studies. The problem with the nuclear studies is that you also get a lot of false positives, meaning that you potentially see what might be some blockage in the heart arteries when actually there isn't. So that's a false positive. So the test is saying there's actually blockage, but there isn't. So that absolutely happens. And that is a dynamic in testing that needs to be understood. Tests can come back positive when there is no pathology in the body. Tests can be positive with no pathology in the body. In other words, the test says there's something wrong with you and there is nothing wrong with you. The only way to figure that out specifically for these stress tests is to then go and get a cardiac catheterization, where they snake a catheter either through an artery in your arm or in your groin up into your heart, shoot IV contrast dye into your coronary arteries to see if there's an actual narrowing or a blockage. And that's all fine and dandy, except that procedure itself is invasive and has some risk. So that's the other thing to know, is that the test itself may involve some harm, whether it be the risk of putting a hole in your aorta in the case of a catheterization, or in the case of CT scans, it actually is the equivalent of about 100 to 120 X-rays just in one 5-second CT scan. And the American College of Radiology has even come out and said that it absolutely increases people's cancer risk from radiation exposure just from CT scans. And they even estimated that thousands or even tens of thousands of cancers a year were actually due to radiation exposure from CT scans. So anyway, I'm not saying don't get these tests done, but I'm just saying that don't think it's harmless. Like, forget about the money, but just don't think these things are harmless if you get them done. You and the physician need to be as rational as possible when ordering these things. Another one, doesn't really hurt you, but full body skin exams by dermatologists. The U.S. Preventive Services Task Force has actually looked at all the data and has found that this does not decrease morbidity and mortality from skin cancer whatsoever. So it's really not necessary. And if anything, it only results in the removal of more benign moles than is necessary. And then you just have the pain and the scarring and the risk for infection that you don't really need. And then so you get some potentially unnecessary testing, and then you get some unnecessary surgeries, where one of the big ones is spine surgery, where there have been numerous studies that show that spine surgery, frankly, it's about 50-50. In other words, about 50% of the time it actually will result in improvement in the symptoms, and that symptom is typically pain or weakness or numbness. And about 50% of the time it doesn't. It either makes it the same or even makes it worse. And so I'm sure many of you know people that have had spine surgery for, let's say a sciatica or radiculopathy, what have you, and they've gotten much better. And that's great. And in that case, the surgery was absolutely appropriate. But in the other 50%, there's also been cases where there's been the surgery, and obviously it was either the same or worse. They go in for multiple surgery, and it just becomes a disaster. And unfortunately, oftentimes these patients become, are in chronic pain, and that's where, like we see in the newspaper almost every day, they become part of the opioid epidemic. And so rather than exposing people to these highly addictive medications, I mean, obviously you don't want them to be in pain, but you also don't want them to be addicted. Anyway, the point is that the spine, as you can see, there actually is a really great picture of the spine. So this would be the anterior, this would be the front of the spine. Oh, little did you know, you're going to get a brief anatomy lesson here, right? So those are the vertebrae, and those are referred to as the vertebral bodies, and those are the cartilaginous discs that are in between. I think this is just a model of a spine. It's not an actual spine. And these are the spinous processes that are coming out the back. So these are the ones that you can actually feel when you push on your spine. So those are the spinous processes. And then if you've ever heard of these things called like a lumbar puncture in order to get cerebral spinal fluid out, something that we commonly did, we would typically go in here around L5, which is around here or here, because you can see that's where it's the widest, and we would actually stick a needle through the skin and extract the cerebral spinal fluid, because here is where the spinal cord is, and then each of these yellow things are the nerves coming out of the spinal cord. And the point is that a lot of the back pain can be related. All of these, what you don't see here, are the ligaments that connect bone to bone, the tendons that connect muscle to these bones, and they're all surrounded by fascia as well, and those ligaments and tendons and the fascia can actually clamp down on the nerves and cause pain. The surgery does not address that. Okay, so that's where things like physical therapy and even chiropractic care and occupational therapy, even massage or manipulation, active tissue release, those things can address pain related to the ligaments and the tendons and the musculature and the fascia that are causing pain. And that's the right thing to do. If there is actual bone impingement of the nerves, then by all means get surgery. Anyway, that's probably more than you want to know about spine surgery. But the point is that you need to go in knowing that half the time it's not going to work. Unnecessary arthroscopic joint surgeries. They did a very famous study where they actually had one of the most common causes for knee pain is just arthritis, wear and tear. And typically happens in middle-aged or older people. And they actually did a study where they said, hey, let's actually do arthroscopic knee surgery on half the patients, and then let's actually do a sham surgery on the other half of the patients. In other words, they literally put them to sleep. They took them into the OR. They actually cut small holes in their skin to make them think that they had surgery, but then that's all they did. And they sewed up those little holes. And this study was about 10, 15 years ago. And then they followed the people who actually got the arthroscopic knee surgery for arthritis, and those who didn't get the arthroscopic knee surgery for arthritis, they got the sham surgery. And guess what happened? Their outcomes were exactly the same. Isn't that interesting? So certainly for like a completely torn ACL, the arthroscopic knee surgery might be completely appropriate, but for something much more common like arthritis, it just doesn't work. Increased chance of complications and postoperative infections. All comers for all surgeries, complication rates like 5%. Okay, so it's 1 in 20 as far as like hospital readmission or postoperative infection or excessive bleeding, what have you. And there's actually a really great website from the American College of Surgeons that is actually a surgical risk calculator. So if you just go to ACS, American College of Surgeons risk calculator on Google, then you can actually type in some things about yourself and the types of surgery, and it'll actually give you a more customized risk profile. That's a great resource for people. Medical errors are actually the third leading cause of death in America. And I will tell you that when I worked in the hospital, I literally saw a medical error every day. Now, oftentimes, didn't hurt the patient at all, but it was still a mistake. Sometimes it hurt the patient and they quickly recovered from it. Sometimes it hurt the patient and they didn't recover from it, but it is common. I would say that if you or if anybody else that you know and love is in the hospital, like somebody needs to be with them all the time. One of the stories is from Johns Hopkins, where I did my training, is that we had one of the attending physicians, unfortunately, his pregnant wife got meningitis. I mean, you want to talk about scary. It was viral meningitis, so fortunately she recovered, but some errors happened to his wife in the hospital. He couldn't believe this. And so he literally got a cot and he parked himself in his wife's room. And he talked to like every single nurse, every single doctor that like came into his wife's room during her 5-day stay. And he just did that because he had to be on guard. So if that's true at one of the best hospitals in America for a physician's wife, then it's probably true for anybody when they're having any experience in a hospital. And then overly aggressive care can generate mistakes and injuries that can cause upwards of 30,000 deaths per year. I mean, this is, I'm not trying to be extremist or like a muckraker, but the point is you got to be careful. You got to be careful, okay? Now, the flip side is that you can also get complications from undertreatment. So I'm not saying all treatment's bad. I certainly would never say that. In fact, sometimes folks aren't treated enough. For example, for high blood pressure and diabetes, these are classically undertreated problems where the hemoglobin A1C is too high, the blood pressure is too high. They're both silent killers. You don't feel this, but they can ultimately lead to kidney failure, heart disease, stroke, blindness. 90% of those treated with diabetes don't have adequate blood sugar, blood pressure, and cholesterol control. So it's the overlay of the diabetes, the blood pressure, and the cholesterol that causes damage to the cardiovascular system. So you can't just treat the blood sugar. You can't just treat the blood pressure. You can't just treat the cholesterol. You really have to treat all three and get all three under control. And if that doesn't work, then that person's going to end up costing $350,000 to $700,000. We've seen some folks cost over $1 million. This woman in Illinois, who's an employee of a client of ours, cost $1 million a year for dialysis. And yeah, you're going to be on dialysis for like a year or two before you get on Medicare, but that's a lot of expense for the plan to handle. And here's also what happens when you pick the wrong doctor is that people are oftentimes put on brand name medications where they don't need to be. And as we all know, specialty costs continue to rise. Most companies are overpaying for prescriptions by as much as 50%. And there's a variety of reasons why people are being prescribed too many brand name medications. So one is they're being prescribed a medication, frankly, when they don't need a medication. So point number 3 here is exactly to that. So antibiotics are overly prescribed for upper respiratory tract infections and ear infections when they're typically viral, especially in the case of bronchitis, which is in the classification of an upper respiratory tract infection. Bronchitis is almost always viral. And so just being prescribed an antibiotic, and especially a brand name antibiotic, does nothing to decrease the symptoms or to make the duration of the illness shorter. It does nothing. But here's what happens, is I'm going to give you a little bit of immunology, probably more than you want to know. So your body's sort of supercharged cells in your immune system are called your T cells. And your T cells actually can latch on to a virus or a bacteria, and they can identify specifically what type of virus or bacteria that is. And then that particular T cell then has to go to your lymph nodes to then be cloned or replicated literally millions of times so that that T cell that is particularly good against that particular virus or bacteria can start attacking it en masse. And that whole process of T cell clonal expansion takes about 3 to 5 days. So what happens is that you start feeling sick, and by day 1 and day 2 and day 3, you start getting a little impatient about how bad you're feeling. So you go to the doctor, you get prescribed an antibiotic, and then on day 4 and day 5, you get this massive T cell expansion, and then on days 6, 7, 8, and 9, those T cells wipe out your illness, and you think that it was the antibiotic that did that for you because you were prescribed it by the physician around the same time that your T cells started massively expanding. Now, of course, if you actually do have a bacterial infection like strep throat, then the antibiotics are absolutely going to help. But the point is that there are many situations where people are prescribed medications where, frankly, they just don't need them. Next is not taking advantage of generic medications within the formulary that would be very appropriate in that particular situation. I won't get into that now. We've had multiple webinars specifically about greater use of generic medications. And really the last point on the slide is not implementing step therapy or exploring clinical or non-clinical strategies that might be more cost effective. So step therapy is, there are many cases where it makes clinical sense to start a less expensive generic medication before moving on to a more expensive brand name medication. And so that's like totally legit. And so the point is that you want to have the step therapy clinically aligned with really best practices or standard of care, if you will, and then overcommitting communicating with both the employee and the physician around that step therapy. We do that for our members at Compass. The breakdown in step therapy is typically when there's an improper communication or just not enough communication between the plan and the members and the plan and the doctor around what the steps are and what they need to do to walk through the steps. But we have a lot of groups that have step therapy, and if you over communicate around it, it can be very successful in terms of getting people on medication. Frankly, too, a lot of times these medications that are in the initial steps have a better side effect profile than later, more expensive medications. So if you can treat the illness not only at lower cost, but with lower side effects, then of course you want to do that. And then the last point here about non-clinical strategies that might be more cost effective. This is where everybody knows that about a third to almost a half of a specialty pharmacy spend is actually within the medical claims, not in the pharmacy claims. And this is where the site of administration can actually dramatically change the price. So a common example there might be like Remicade for Crohn's disease or ulcerative colitis, where the infusion at the doctor's office or the infusion center might be $500, $800, $1,000, whereas hospital-based infusion might be $2,000, $10,000. We had one member that was literally getting $25,000 a month Remicade infusions. That is excessively expensive. So there, you're not changing the medication at all. It's the exact same medication. It's just because of the way that the particular facility is contracted for the dispensing of that medication or the administering of that medication that dramatically changes the price. So anyway, probably more than you ever wanted to know about branding medications, but who you choose as a physician sets you on the path of those decisions down the road, which is why choosing the physician is so important. Okay, so as it relates to navigation, I would say that in the beginning, when people were trying to be better healthcare consumers, it was about trying to lower the unit cost of something like an MRI by going to a more cost-effective MRI facility versus a hospital. And that is a valid strategy, and that is a good strategy. However, that's really just the beginning, where really health navigation is helping employees make simpler, smarter healthcare decisions in terms of actually choosing the right physicians that are already set up to be clinically of higher quality, greater efficiency, performing tests and procedures at more cost-effective facilities. So oftentimes people don't realize how maybe choosy they need to be in their physicians. And I will tell you, the people who are most choosy in their physicians are probably physicians and nurses themselves, because they know all of these providers are not created equal, that even providers are on a bell-shaped distribution, and not everybody is in the top half. So kind of a ridiculous comment, right? Of course not everybody's in the top half. And so really when we say finding the right physicians, we almost mean finding the types of physicians that doctors and nurses themselves would find for themselves or their family members. And it involves kind of these two large elements. It involves solving the employee hassle problem and solving the cost problem, both at the employee level and at the employer level. And the reason that's important is because oftentimes the administrative hassle associated with healthcare becomes just obstructive, and then people just take the path of least resistance and say, well, I'm just going to go to this doctor because they're close or because they have easy appointments, and they don't make the extra effort to be like, okay, but are they going to know what they're doing? And so that's where it's like, okay, well, maybe what if a dedicated resource or expert or what have you could not only find people that are close and that meet your appointment availability timeframes, but also like know what they're doing. That's really the sweet spot that you're looking for. Or maybe it means going an extra 5 miles. But maybe if you knew the downstream repercussions of going those extra 5 miles, then of course you'd go those extra 5 miles. Or maybe you'd wait another day. Instead of going on a Thursday, maybe you would go on a Friday, even if that's more inconvenient for you. And that, by really matching, that's really where the magic happens. And in medicine, it's called the doctor-patient therapeutic relationship, is that really high-quality care is cost-effective care. And that is most often achieved when there is that therapeutic relationship between the doctor and the patient. And so it's not just about the unit cost problem of lower cost MRIs or colonoscopies, what have you, but it's also the overall plan of care and plan of diagnosis as formulated by the physician in a therapeutic relationship with the patient that leads to the best outcome. Well, that requires data, it requires research, it requires an educated decision-making process. And so we're going to go through some of these educated decision-making processes, if you will. So these right doctors, in other words, the type of doctors that doctors themselves would go to, they provide high-quality, cost-effective care. Interestingly, oftentimes, there's another company that actually did a study that found that when doctors care for other doctors, they actually typically end up doing less than they would for a typical patient. Isn't that interesting? They're more likely to make objective referrals based on their understanding of quality. So in other words, it's not just, hey, go find a gastroenterologist, or hey, just go find a gastroenterologist who's a buddy, but they know that this gastroenterologist performs well. And to a certain extent, the way that they know that is actually not through outcomes, but it's by working alongside of them or working with them on common patients and listening to that and listening to them speak about their patients and listening to them in terms of how they think about their patients. Because when a physician, a physician knows when another physician actually thinks about their patients in a rational, objective fashion. And it's that type of thought process that you're looking at. And you want to base your referrals off of that type of thought process, not around, who you're friends with or who's convenient. Especially for the surgical subspecialties, it means evaluating all treatment options before surgery, which at the end of the day, I will tell you the vast majority of surgeons actually do that. But I would say there is a healthy minority, so it's less than 50%, but it's probably more than 10% that are probably more cavalier than would be appropriate. So it's not necessarily, so it's really a matter of staying away from those folks. And then considering low-cost medications before writing a prescription. So this is where, at Johns Hopkins, where I did my residency, I mean, we weren't like, quote unquote, forced to use a formulary, but we were very cost-effective in our prescribing because literally our patients in East Baltimore were making decisions between, paying the rent or buying groceries and their medications. And so, we knew for the sake of our patients, they needed to get groceries and pay their rent. And that if we could find a way to treat their condition but allow them to afford their life, then that would be incredibly helpful for them. So all we try to do at Compass is frankly mimic that approach to prescribing. So let's take a look at this in a more patient-specific sort of microcosm way. So an employee needs to find a specialist who can perform a particular eye surgery for his wife. See what happens when he does not reach out to healthcare navigation support, i.e. Compass, and when he does reach out to healthcare navigation support to find a high-quality in-network specialist. So this is specifically an ophthalmologist, eye surgeon, right? So without healthcare navigation, they just use Dr. Google, right? Look for people in the area for the particular eye surgery. They may or may not even be paying attention to their network status. The provider selected was not contracted with the insurance, which a lot of ophthalmologists are not. And the patient also found the provider's bedside manner was poor, because that's a hard thing to kind of figure out just from Dr. Google. But he did not know who else to see in the area. So a lot of times people just don't even take the time to do the exhaustive search that they need to. So the doctor performs the surgery on both eyes. They're out of network. And at the end of the day, this is really important, because when you go to a doctor's office or a facility and they say, we'll bill your insurance, that is not an answer to the question of, are they in network? Okay, so oftentimes they'll use that euphemism. Sure, they'll bill the insurance, and then the insurance is going to be like, oh, you're out of network. And that's going to fall to your out-of-network deductible or your out-of-network co-insurance amount, which everybody who has insurance, they actually don't have one deductible. They have two deductibles. They have their in-network deductible and their out-of-network deductible. So this is where people might have met their in-network deductible, and they're like, okay, I'm done. And then they go to an out-of-network provider, and they're starting from scratch on their out-of-network deductible. And even that basic concept is oftentimes lost on employees and their family members. So a few years later, employee visits the provider again and needs to have additional eye surgery. The employee follows through with surgery of both eyes because a few years later, maybe they've forgotten the pain, not literal physical pain, but the financial pain of going to that out-of-network physician. But the provider is still not contracted with their insurance. So in total, not only the $8,000 initial surgery, but the $14,000 subsequent surgery for a total of over $22,000. Versus with healthcare navigation, the employee contacts their health navigation vendor, i.e. Compass, needing to find an ophthalmologist for vision correction. The health pro screens physicians in his area and finds high quality providers that specialize in that particular type of vision correction. So it could be like a what's called photocoagulation or laser surgery for vascular proliferation secondary to diabetes. So that's a fancy way of saying diabetic retinopathy. Which, by the way, diabetic retinopathy is I think the leading cause of preventable blindness. And so the doctor is not only in network, and thus it's only a $40, $50 copay for the office visit, but during the new patient visit, the office provides excellent service and bedside manner is outstanding. And so this is where Compass specifically screens the physicians for their bedside manner as well. And this is where we don't specifically ask the doctor, hey, what's your bedside manner? Because as you can imagine, they're real busy going room to room. We can't necessarily get them on the phone. But we actually have questions that we will ask the office staff in regards to their bedside manner. And they're actually very forthcoming with that information. And so we can then take that, and it might not be the only criteria that one would use, but certainly you would want to have that as one of the pieces of information in making a decision about a physician. And we literally talk to over 25% of physicians' practices over the course of the year, and we've been doing this for over 10 years. So over time, we have accumulated this huge mass of, frankly, sampling data or survey data, I should say, around bedside manner. And that's found to be incredibly helpful. I think it was either on a previous slide here or later on that the Net Promoter Score, or the satisfaction that people have with Compass recommended physicians, is like a plus 77 versus only like single digits or like plus 12 for your typical just random search for a provider. So this is where, you're talking a 5 to 6 times better physician experience, in part because of that bedside manner screening that Compass is doing. And so this different eye surgeon, it actually suggests a different type of eye surgery. So because we found somebody that specifically specialized, let's say they actually were not just a regular ophthalmologist, maybe they were a retina surgeon and really knew the latest approach to diabetic retinopathy. It's not really surgery, if you will, but photocoagulation is still a procedure. Due to the doctor using the most up-to-date, proven procedures, not only is the employee's eye condition improved, but the procedure used was also able to prevent the need for a second surgery, saving the member from additional procedures. Total cost $13,000 versus $22,000. So this was not about shopping facility costs. This was about finding the right ophthalmologist for this particular member. Okay. Example number 2. An employee is looking for a chiropractor and is given a name from a good friend. So this is where at Compass, we help a lot of members with like non-physician providers. So a chiropractor would be a non-physician provider, physical therapist, occupational therapist, speech therapist, audiologist. So there's quite a bit of, even optometrists, oral surgeons, dentists. There's quite a bit of assistance with these still healthcare providers, but not necessarily MDs or DOs. So see what happens when she does not confirm the doctor's network status where she goes. Employee suggesting name of a quote, get it from a friend. I mean, that's where a lot of people are getting this information from. Employee decides to set up an appointment with the chiropractor who's, again, out of network. The employee does not check prior. Maybe the office says, hey, sure, we'll bill your insurance. The chiropractor creates a treatment plan and tells the member that they will need bi-weekly visits for a year. And this is the challenge where oftentimes, and we can even see this in our data, whether it be a physical therapist or a chiropractor, where we will see that for a particular patient over a course of time, that they'll have like 16 visits, because oftentimes 16 visits is like the maximum allowable. And so like regardless of the chief complaint or the reason for seeing that therapist or that chiropractor, they always get 16 visits. Well, that's kind of fishy, right? Because there's different degrees of severity or types of problems, some of which might require 16 visits, but some probably only require like 2 or 3. Because a lot of the times, especially with physical therapists, it's a matter of teaching a particular exercise, which then just needs to be done at home. And there's no actual value of just doing it in the office. So, so that's where like looking at the data and looking at the practice patterns from the data can be very helpful in terms of being like, hey, is this just a cookie cutter person, or is this somebody who actually varies their treatment plan depending upon the severity or the type of problem? So with healthcare navigation, the employee attends open enrollment meetings, told about their healthcare navigation vendor like Compass. A month later, the employee is looking for a chiropractor, and a friend suggests a name, just like in the first one. But the employer reaches out to the healthcare navigation vendor to screen the provider, and they find a provider. The vendor suggests an in-network, 3 in-network options. So in other words, they took the friend's recommendation, went to Compass. Compass said, look, that person's out of network, but here are 3 in-network options. Say, hey, look, there's only a $30 copay for this particular plan designed for chiropractic visits. Then the employee schedules an appointment with that person, attends the visit for a $30 copay, and then this particular, because we know from their practice patterns that they have a more, let's just call it a customized treatment plan as opposed to a cookie cutter treatment plan, that they only need fewer visits. And so as a result, it only ends up costing $810 as opposed to $25.80. So even though this isn't like tens of thousands of dollars, I mean, that is still real money for both the plan and the person. And also it saves them a tremendous amount of time. I mean, we've got a lot of like law firms that are clients, and these attorneys or paralegals cannot be going to the chiropractor all day. It's incredible. I mean, they got families, they have cases. So it could be anybody who's dealt with a chronic healthcare problem knows how much time can be spent in dealing with it. Next. An employee's wife is planning to have a baby in the next few months. She already has a provider, but wants to know the estimated cost for the delivery. See what happens when she does not utilize healthcare navigation as a resource versus when she does. Okay, so this is first without navigation. So an employee's wife's planning to have a baby in the next few months. She already has an OBGYN, but wants to know the cost. She contacts the doctor's office. Doctor's office tells the patient that they only know their costs for the physician, but not for the facility, the hospital. And that's actually where the majority of the cost is. The doctor also tells the patient that she uses 2 hospitals, and the wife and the employee decide on hospital A, not knowing that it costs $7,000 more for labor and delivery than hospital B. So oftentimes, especially in cities and in suburban areas, an OBGYN or OBGYN practice might actually have admitting privileges at multiple hospitals or birthing centers. And this is where again, that physician fee, oftentimes they do a global fee for both the prenatal period and the delivery, might be like $2,500. So that's not going to change, but the actual delivery will change, whether it be a normal vaginal delivery or a C-section. Okay, so over a year later, the employee's wife has another baby, but finds out her OBGYN is moving to another state. So she asks a friend for the doctor she sees, so in other words, a new OB. However, the provider uses a facility that is more expensive than the area average. Total cost for the 2 babies, $32,501. Okay, so with healthcare navigation, employee's wife's planning to have a baby in the next few months. She already has a provider, but wants to know the estimated cost. So instead, she emails her healthcare navigation vendor. That vendor screens the OBGYN, confirms she's in network, but finds that she uses 2 hospitals, with one being drastically more expensive. So here, we're not forcing them to go to one hospital over the other, but like, look, there's a price difference between these 2 particular hospitals. Over a year later, the employee's wife is expecting another baby, but finds out her OBGYN is moving, just as in the first situation. The navigation vendor steps in to locate another provider at an affiliated hospital, again making sure the providers are in network, high quality, and and offer cost-effective care. So here, the 2 babies cost $21,140, over $11,000 difference between the 2. And again, it starts with the choice of the physician, and then the choice of the facilities within that physician in this particular scenario. Next, let's talk about dependent care or care for children. So an employee's son has a diagnosis with asthma. My 2 sons themselves have asthma, and he needs an inhaler. See how the healthcare experience can be positively impacted when an employee reaches out to healthcare navigation support for prescription review, provider recommendation, and overall continuous assistance for a chronic disease, their asthma in this case. So without healthcare navigation, an employee's son has a prescription for an inhaler. She goes to the pharmacy, picks up the brand. With refills, the inhaler for the year is going to be $13.20. Inhalers can be very expensive. These things have been around for a long time, probably late 70s, early 80s. And I won't get into why they're still expensive, but they are. A few months later, during a visit, her son's pediatrician suggests seeing a pediatric pulmonology specialist. The employee takes her son to the doctor's referral, but is unsure if the doctor is in network, high quality, and cost effective. By chance, the doctor is in network, but the one of the more expensive providers in the area, and suggests that her son have several expensive tests performed. So this might be blood tests measuring something like eosinophilia or various immune globulin levels. It could be a pulmonary function test with what's called a methacholine challenge. Due to the doctor's recommendation, the employee's son proceeds with the expensive testing. Before his follow-up appointment, the employee's son has an asthma attack, so the employee rushes her son to the hospital. So here it is, even during the diagnostic time, they have a flare-up, and they end up having to seek urgent care for that. Total cost $4,770. So now, with healthcare navigation, employee's son has a prescription for an inhaler. She contacts her Compass healthcare navigation vendor and asks for a prescription reviewed if there's any way to save money. This says, okay, that there is a significant savings with mail order, right? So this is, well, you know you're going to need your inhalers, so there's a significant markup. So there's actually, it doesn't take it down to zero, but there's a significant savings in just how you get that inhaler filled. A few months later, during a visit to her son's pediatrician, suggests a pediatric pulmonologist. But the person says, well, let me contact my Compass Health Pro navigator about that. The health navigation vendor recommends 3 in-network, high-quality, cost-effective providers, as well as nearby in-network urgent care centers. So there, health navigation has proactively said, look, people with asthma oftentimes do have urgent or emergent care needs. Let's at least prep you with a location that you can go to should you need it. And an employee takes it to the recommended specialist. The doctor communicates that she wants to provide the best care possible to the employee's son, but does not want to order the unnecessary or expensive testing. So this is where, listen, if the person, by history and prior records, which, oh, by the way, Compass would even move the prior test results. Maybe the person had pulmonary function tests like 2 years ago. You don't necessarily have to repeat them. And so in this case, the person said, well, listen, I'm an expert, I'm a professional, but I don't necessarily need to retest the diagnosis. What I need to do is reevaluate maybe the treatment plan. Maybe that's what I need to change. Maybe I need a prolonged inhaled steroid in addition to a beta agonist, or maybe I need a long-acting beta agonist, or maybe I need to use a nebulizer instead of an inhaler. Maybe they're just not using a spacer. If someone's having an inhaler, if you don't use a spacer, you're not getting the adequate use of the medication even in the inhaler. I've seen people literally be turned around with their asthma just with the use of a spacer as opposed to no spacer. So here the employee's son has an asthma attack while at home, and the employee takes the son to the urgent care center that was already recommended by the healthcare navigation vendor. We even have folks, when they go on vacation, they contact their Compass Health Pro to find in-network urgent care places where they're going on vacation, because it's Murphy's Law, right? If you're going on vacation and you have kids, guess what? You might need to go to the urgent care place. And so I will tell you that especially if the vacation is in more rural locations, that can be especially helpful. Okay, so that brings us to really the why for Compass. So the point is that with healthcare navigation, it is about finding the right providers early on in the process, whether it be right primary care physician or right orthopedist or right ophthalmologist. And that by getting people on the right track from the start through a combination of survey data that Compass has and claims data that Compass has, and also publicly available data, both at the state and the national level that Compass has, that you're able to save over $1,100 per user per year. And when we say 25 times better care, again, that's the patient satisfaction score of a plus 77 compared to those employees that just find it on their own. And again, I would say too that actually is helpful because that plus 77 is really indicative of a positive, healthy, therapeutic relationship between the physician and the patient. And that's important because where there is that relationship, there is trust. And that trust is super important in terms of the patient listening to the doctor and being compliant with the doctor's orders and being adherent with the doctor's medications. Because at the end of the day, even if the person goes to the best doctor in the world, if they don't work together as a team, then they're not going to have the best possible outcome. So I don't want to, I don't think I could I could say enough about how important it is to have that right fit and to have that plus 77. And also the guidance is timely. That's what we mean when we say guidance when we need it most. I mean, it's not about educating people during open enrollment, because like the vast majority of people don't need healthcare during open enrollment. They need it during some other point of the year. And just to have that just in time, point in time expert resource is has been truly effective in terms of behavior modification. And then lastly, it makes people actually feel like their benefits at work are a benefit. It's not a point of frustration. It's not a point of consternation. It's not a thorn in their side. If anything, it can even tighten the relationship between the employee and their employer, because they're like, look, my employer, they really took care of me. I was really in a tight spot and they really helped me out and they really got me or my family member out of a bind. And we get stories from our members every week and feedback from HR people every week about just that. And that's where at Compass, our healthcare navigation services are specifically designed to address the administrative and health system navigation and even clinical pain points of people as they navigate their benefits and as they navigate healthcare. And it is just, and literally, and sometimes this is serious stuff. I mean, we literally do over 1 to 2 hospice referrals a week, and we do over 1 to sometimes even upwards of 3 referrals for addiction treatment centers per week, whether it be prescription opioid addiction or drugs or alcohol. And I mean, I was just telling a broker earlier today, I mean, this is serious stuff. I mean, this is life-changing, family-impacting stuff. And it is, I'm just humbled and honored that we have the opportunity to work with our clients on this and to work with employees and their families on this. And it just makes me so excited to be able to really help people when and where they need it. And so I'm just incredibly appreciative to all of you for listening to this webinar and being partners with Compass, being potential partners with Compass. And I want to go through some ways that you can stay on top of the latest HR and benefits issues as well. So one is through our Compass blog, where we literally have thousands of people a month reading this blog. It's been going on for many years. There is a recent one on PBMs that has been particularly of interest to people. We have recorded all of our prior Compass webinars at our Compass website, phs.com/webinar. So if you want to listen to a prior month's webinar, like I said, we have quite a few about prescription drugs. Those are particularly of interest as well. We also have a podcast series now. So when you are driving, when you are commuting, or like when you're doing the dishes, if you want to listen in to your Compass podcast, I found it's a great way to make use of time when you're doing other things. And with that, again, I want to thank you all for giving me the most valuable thing that you have, which is your time and attention. And with that, I hope you have a fantastic rest of your day.